Okay. Okay, Dr. Stille, we're right at 12 o'clock. Are you
All
ready?
right.
Do you want to go ahead and get
I'm
started?
ready. Yeah, I'm ready.
I love it. Okay. Okay, everyone, welcome back to another health talk. Today we've got Dr. Kacy Stille. Dr. Stille is an OBGYN at Women's Health in Boone. Dr. Stille, I've absolutely loved my time getting to work with you. And just a fun fact for everyone listening, Dr. Stille and I were on a podcast last week, right? So that's really
It's
fun.
true.
And so that's actually another plug for our podcast. So we are partnering, our healthcare system is partnering with High Country Radio in Boone to host a health podcast. Our first podcast guest was Dr. Molly Benedum with the Family Medicine Residency at App Family. And then our next episode, which will come out the first week of June, will be with Dr. Stille and Dr. Coiner. Another great talk about women's health. And today we're going to talk about perimenopause and hormone replacement therapy. And we have a lot to cover. Dr. Stille, I'd love for you to kind of introduce yourself, talk to us about yourself. I always love hearing about your time in Alaska, so please share about
Sure.
that. And then we'll
Sure.
hop right in and get started.
All right. Well, thanks for taking the time to talk today, everyone. My name is Kacy Stille. I'm an OBGYN here. I've been here since last summer. My family and I moved here just from Elkin, where I had a short stop there, and we're in Alaska for 12 years before that. I have a wonderful husband, Ted, and three wonderful kids, Zoe, Henry, and Wiley, and they are in the public school system here, which I love. And we've just found Boone to be such a wonderful, welcoming community, and we love being here in the mountains.
Well, we love having you here. We love having your whole family. It's just
Thanks.
great. Okay, so to get us started, again, we're talking about perimenopause, hormone replacement therapy. And for all those that are listening, I just want to also give the FYI that your cameras are turned off, your audio is turned off. But if you'd like to communicate with us or ask any questions, please send us your questions in the chat. You are welcome to send those questions to me directly in the chat, or you can put them in the chat for everyone to see. I will be monitoring the chat, and please feel free to chime in and ask questions. And I think that's all of the things. I always forget all my little spiel at the beginning of all the little things, but I think that's everything. But I did want to get us started off with a fact that I read in prepping for this health talk. And Dr. Celia, I sent it to you ahead of time, but I saw a study that surveyed close to 1,000 perimenopausal women, and the study found that 63% of women sought information about perimenopause or menopause from their friends. So that means less than half sought information from their actual healthcare provider. I thought that was interesting. And the study was in 2022, so that was just a few years ago. And I think now, even just 4 years later, I think a lot of women are getting a lot of information online or TikToks or podcasts, rather
Yeah.
than actually coming to their healthcare provider. And I just wanted to ask you, why do you think that is? And is that a good thing or a bad thing? Or what did you think about that?
Yeah. Well, I do think it's kind of a chaotic moment for
Yeah.
menopausal women and perimenopausal women because of all of these streams of information that we're getting from media and from friends and everything else. I think that the interesting thing to think about is that there's been, over the past 20 years, more education about like puberty and helping girls prepare for the transition when their hormones are going to start to go crazy. And on the other end of that, when our hormones start to fall, there's really not been a parallel path for women to understand these physiologic changes that are happening in their body and to recognize some of these symptoms in the early stages when they're happening. And so I think that discussions around this that have come up because of social media are good in that we're talking about them, right? Women are
Yeah.
communicating and not living in these silos and suffering. And so, in that regard, I think the social media realm and discussion around this has been very liberating
Mhm.
for women to have a community in this time that's so
Yeah.
crazy. But I do worry that women are not seeking care through the traditional realm of OBGYN and care providers. And that's why I kind of wanted to have this meeting today in my office, which everyone's always worried about coming to the OBGYN, but it's pretty nice in here. It's not
Yeah.
that bad in exam room. I'm not
No.
that, I don't bite, and so I really wish people would come to us and get good healthcare through their normal pathways, not through supplements, not through online MIDI. I mean, there are plenty of places that if you are in a rural setting, you don't have access, that it's great that we have telemedicine and we have different venues for people to seek care. But I do think that it's important that we try to get care through the normal pathways for these type of situations. I don't know. That's a roundabout answer to your question, I think. But
No, that was no, that was perfect. And I agree with you. I think it's great that we're having these conversations on social media and other platforms. It helps women to feel less alone. But at the same time, it's not best to turn to Dr. Google all the time. Dr. Google is not always right. And I am happy or fine to admit that I'm not a great patient, that I'm like every other person in the world that tends to go to Google, and Google's not always right. So it's nice to know that you're right here. You're right here in our corner. You're happy to help. Um, okay, so I just wanted to start off with that fun fact because I just thought that was really interesting that so many women are going to their friends or other outlets rather than coming to
yeah,
their healthcare provider. But before we really dive into some perimenopause stuff, can you help briefly explain what is the difference between perimenopause and menopause?
sure. Yeah. So perimenopause traditionally is thought of as like the 5 years before you stop menstruating and the year before you've reached menopause. So it's a very kind of antiquated definition. The definition of menopause is 1 year after you've stopped having any periods. Well, that's really confusing because it's only effective retroactive, right? You only know you're in menopause after you've been there a year. And that when you're in this interim where you haven't had a period for 6 months, but you're not really menopausal, what are you? And so that's where this term perimenopause comes from. And really the thought experts now are saying, this period can actually be as long as 7 to 10 years. And the myriad of symptoms that accompany perimenopause are not just the irregularity in your menstrual cycle. So traditionally, that's what we've used as the kind of marker, either when periods get further apart or when they're irregular, or sometimes women have really heavy bleeding, sometimes they have light bleeding. But there are a bunch of other changes, clinical features that we see sometimes even before we see that. And those can be really, it's a weird thing to try to quantify, but patients just come in and say, like, I just don't feel like myself anymore. I feel like, I don't know, I'm not living my best life. I don't feel like I was 6 months ago. And it's kind of a period of disorientation in the hormonal cycles. And, that can be sleep disturbances, that can be brain fog, anxiety, depression, tearfulness, irritability, anger, trouble concentrating, and then the vasomotor symptoms that are associated with sometimes hot flashes. And there are also in the perimenopausal period some physiologic changes that we see that are not necessarily recognized by the patient, but we're seeing in blood work. And those can be increase in LDL. People saying they're gaining weight. I'm doing the same thing in terms of my exercise. I'm eating the same thing. I just really am gaining weight. And so there's a insulin resistance that comes all around in this perimenopausal period. And so those cardiometabolic changes that are happening beneath the surface are real. And, it's really been a paradigm shift in recognizing this in the past little bit, because it used to be sometimes doctors would just say, well, you just haven't been taking care of yourself and you're finally getting around to taking time for yourself. Your kids are older. And so that's why these things are all coming to light. And it's not gaslighting, but it's not really acknowledging that these are physiologic changes that are happening, and they're real. Your experience through this perimenopausal period is going to be different than your neighbors. It's going to probably be different than your moms or your sisters. And your varied symptoms can be related. Now, there are also things that, it may be your thyroid. There may be other things that need to be evaluated, and we can't just blame perimenopause on everything. But some of these changes are due to the chaotic period that's happening. And so kind of what is happening physiologically in this period is your ovaries are not functioning at the level that they were when you were having normal menstruation. And when your ovaries are not producing the estrogen and the progesterone, there's a signaling molecule called FSH. And that follicle stimulating hormone is the hormone that we test to see if you're in the quote unquote menopausal range, because this estrogen and progesterone goes up and down and up and down during your cycle and during the day. And so it can be low or it can be high. But if the FSH is high, that's saying your estrogen and progesterone are probably pretty low. Okay. So in the perimenopausal period, what is happening is the FSH is like yelling at your ovaries, make more, make more, make more. And sometimes they respond and sometimes they don't. And so that's why sometimes your estrogen can be fine and you feel normal and you're able to do your daily things. And then other times you can't remember the name of the person that you've sat with in the office for the past 5 years. And you have this brain fog and feel like you can't function at the level you've been able to in the past. And so it's really this fluctuation that is driving women crazy. And this oftentimes resolves after you're like through perimenopause, like 3 years after you had your last period is when the FSH really starts to go down. And yeah, so that's kind of what is happening and why we have this ill-defined period of perimenopause. So I can't say with fidelity, like if your lab values are this, you are in perimenopause, because we just don't have research around this complex issue. And part of that is a lack of funding for women's health. And part of it is women just didn't take the time to talk about this in the past, and now they are. But hopefully, moving forward, we're going to get better answers and better treatment options around this.
That's what I was just going to ask you. Do you think research will continue to grow and we'll learn more and more about this period? Random question for you. Why, as a species, do you think we as humans or women experience menopause?
Oh, geez. That's a really interesting question. So there are a couple other mammals that have menopause, like orcas have menopause. And there's like some theory around the grandmother hypothesis, like in these species like orcas where there are menopausal women that survive, females within the species that continue, like their offspring do better, like their communities do better because the women are there at a different level contributing than just bearing children. So anyway, that's a little in the clouds, but there's interesting theory around grandmother hypothesis.
Yeah. I was just sitting here thinking when you're describing everything, it just feels like as women, we experience a lot. We go through a lot. And so, when do we get a break? I'm just kidding. Okay, there was another question I was going to ask you. Oh, you had mentioned some of the different symptoms of perimenopause. Now, do those get better as you move into menopause, or do they kind of stay the same, or does menopause have a whole different realm of symptoms?
Yeah, that's a great question. So, these symptoms will start sometimes like 6-7 years before you have that last, age of menopause, so sometimes early 40s, people are start having those symptoms. Some of them do continue through menopause in terms of the vasomotor symptoms with the hot flashes, but some of the dysregulation is better because instead of the hormones being up and down, they're just low. Does that make sense?
Yeah.
And so, that answers your question.
Yeah, it did. And then I had another stat that I had found when I was searching for this help talk. So in a study, and I'm going to have to read it here so I don't get it wrong, but in a study of nearly 5,000 women ages 45 to 60, this study found that 80% of women had not sought medical care for their perimenopause or menopause symptoms. Some women said they preferred to manage symptoms on their own, while others said that they were too busy or they didn't realize that treatments existed. So, therefore, you and I are going to talk about some treatment options that are available. So,
Yeah.
let's talk about hormone replacement
Yeah.
therapy. I want you to tell me what exactly is hormone replacement therapy and talk to me about the different forms. And is one better than the other? Is it dependent on the person? Do you work with your patients to figure out which option is best for them?
Yeah.
Talk to me
Yeah.
about hormone replacement therapy. Women should not have to suffer in silence. I hate to hear that statistic that 80% of people, it sounds like, suffered, before seeking help. So
Yeah.
let's talk about ways that you can get help.
Yeah, I mean, I think, let me just back and say, like, that's why I am so passionate about this, is because I feel like I don't want women in our community to be suffering when we have safe treatment options that are available that increase their quality of life. 70-90% of women are going to experience vasomotor symptoms, and everyone talks about the hot flashes. But when they've done studies and surveyed women about what are the most bothersome symptoms in the perimenopausal menopausal symptoms, it's actually not the hot flashes, it's the brain fog. It's like not being able to function, and also the sleep disturbances. There's like some studies 40 to 60% increased risk of depression during this period of time. So everyone talks about the vasomotor symptoms, but it's these other symptoms actually that can be the most debilitating in a lot of ways.
Yeah.
And it used to be that we as OBGYNs recommended, this is just like 5-10 years ago, that we recommended using the lowest dose of hormones for the least amount of time to get women through the hot flashes. And now we're really in a different space where we're recognizing some of the health benefits that accompany hormone replacement therapy. So
Yeah.
those can be for cardiovascular health. It can be for your mental health. It can be for your sleep. You're not in perimenopause, Maddie. I know that by looking at you. But what I hear every day is women saying, like, I just wake up between 3 and 5 in the morning, and I can't get back to sleep, and I toss and turn, and I used to be a bad sleeper, and so that in and of itself, sleep disturbances are something that can derail women in this period of life. So I don't know where I was going with that, but treating some of these symptoms in the perimenopausal period, as opposed to waiting and saying, well, I'm not going to give you treatment until you've been menopausal for a year, or your lab values are this. That has been a progression over the past 5 years, is that we're not saying let's use the least amount for the shortest amount of time, but saying, like, what can we do to increase the quality of life of our patients by giving them back replacement of some of these physiologic doses of
Mhm.
hormones. And so traditionally, hormone replacement therapy has been thought of as a progesterone and an estrogen. And
Mhm.
so we use estrogen, and there are a couple of different forms of estrogen. There's an oral estrogen,
Mhm.
and there's a patch, there's gels and creams, and then there are some pellet therapies. We'll kind of talk about those last. So the estrogen therapy is different than. Sorry, I'm seeing some of these questions pop up, so I just
We will, I
I'll get to them.
promise to
Yeah,
everyone
yeah.
putting questions, we
Um,
will get to them.
so the estrogen therapy, transdermal is what I recommend as the safest, because it avoids the first pass metabolism of taking a pill and taking it in your, getting it through your stomach and getting it through your liver. It gets absorbed into your skin, and so it gets you to a steady state. It doesn't have the risk of thromboembolism or a blood clot that sometimes estrogens do. This is a different type of estrogen than a oral contraceptive pill. So sometimes patients tell me, like, I could never take birth control pills before. It just made me too moody. And this is estradiol. So it's a different form than the normal traditional birth control pills. And so it's usually pretty well tolerated. And so there are a bunch of different types of patches that we can use. There are a couple different gels that we can use that avoid that risk of a blood clot. And so those are kind of that's what I use for the first line for that type of therapy. The progesterone, that if you have a uterus, you have to do something to protect the endometrium or that lining of the uterus. So if I just were to give a postmenopausal woman estrogen, they would start to have bleeding. We don't want that. So the progesterone helps stabilize that endometrium. And you can have that with an IUD, a progesterone IUD, or oral micronized progesterone, or there's a combi patch that has both. Some compounding pharmacies and things have a progesterone cream, but there is not great evidence that that provides you endometrial protection. So that lining of the uterus can get thick and have precancerous changes if there is what's called unopposed estrogen or estrogen without that balance of the progesterone.
Okay.
Yeah.
And
then vaginal estrogen is something that is really important. And I didn't mention that in the clinical features, and I should, even though I try to write things down. Women describing painful intercourse, loss of libido, loss of being able to achieve orgasm. These are all things that women in the perimenopausal period describe. And part of that is due to the changes in the vulva or the labia and the vestibule and the introitus. Those changes, or you have decreased secretion, so you have dryness. There's also like loss of architecture of the labia as you get older. And so using vaginal estrogen cream, even if this is not perimenopausal, obviously, this is like just incomplete discussion of hormone therapy. A vaginal estrogen cream is something that I recommend for all women for their bladder health and for the health of their vaginal tissue. And that's just a cream that's like twice a week that's used just like a collagen cream. I mean, it's not a collagen cream, but I'm saying equivalent to using like you would use a collagen cream for your face. This is an estrogen cream that gets absorbed just locally on the skin. It doesn't have systemic levels.
okay. Did you want to talk about testosterone pellets or no?
Yeah. Well, so I guess there are some thought leaders that are, urologists specifically, but some OBGYNs also, Robin Rubin, Mary Claire Haver, I'm blanking on the other urologist named Kelly Casperson. They really are thought leaders in using testosterone in perimenopausal and in menopausal women. Testosterone doesn't kind of hit a cliff the way estrogen and progesterone do in the perimenopausal period. Testosterone is kind of slowly going down from your 30s, and so they feel like hormone replacement therapy should be called PET, progesterone, estrogen, testosterone, and that third component of it is kind of the hardest thing because we don't have FDA approved formulations right now that are easy to get. The testosterone dosage that is needed for hormone replacement in this postmenopausal, perimenopausal period is like 1/10 of the male dose. And so there are other places across the globe that have approved treatment options, but for us, it's a little bit trickier. So there are creams and gels that we can use for that. I do not think that testosterone pellets are a great option for hormone replacement therapy because they oftentimes provide supraphysiologic levels of the testosterone, and they get people's levels into an area where they have irreversible changes. And the irreversible changes with testosterone can be male pattern hair growth, changes in the voice, splenomegaly. So those things can be pretty significant when your testosterone gets over 100. And a lot of these women that I've seen getting pellets in our community, their testosterones are in the 200s and 300s, and they're having really bad side effects from them. They're also, it's just a weird dynamic because most of these are paid for service. So, women are paying $400 every couple months to get this pellet, and it's just like a bead of rice put under their skin. And it's nice to not have to think about it all the time, but it's concerning to me, and it's really not what is advocated by American College of OBGYN and the Menopause Society in regard to that.
Yeah. Who who is a good candidate for hormone replacement therapy? Is there such thing as a bad candidate for hormone replacement therapy? We're getting some questions in the chat about cancer risk, or this person said, how do you balance HRT with a higher risk of cancer from family history that is thought to be
Yeah.
directly related to hormone replacement therapy?
Yeah. So actually, when they've looked at the studies of the formulation of the estrogen and progesterone that we are giving, there's not significant increased risk in breast cancer, which most women are the most concerned about. And the formulations for the micronized progesterone, which is what we're using right now, is very different than what WHI, which is the women's health initiative that was stopped. That was using a different formulation of progesterone. And so that was stopped for a myriad of reasons, but the concern for breast cancer risk is really not significant with the formulations that we're using right now. So in my mind, I think all women should be offered hormone replacement therapy because of the overall health benefits, longevity benefits when you look at it for osteoporosis, when you look at it for cardiovascular disease. And that's just, that's where I'm coming from, because women in our society now really are not dying of breast cancer. They're dying because they have osteoporosis and they break their hip, and then, they're in a 40% of them are in a nursing home in the first year, and, they have recurrent urinary tract infections because they don't have any vaginal estrogen, and then they get septic, and then, so I am looking to try to increase women's quality of life. And what's challenging for me is I don't have the fidelity of data that like a cardiologist has. I can't say like giving you this statin for 10 years will decrease your chance of having a heart attack in the next year. What I can say is we have a significant body of evidence pointing to one direction, and we may not get hard data to say this using estrogen is going to decrease your risk of having coronary artery disease by X amount, right? We're not probably going to get that information for the next 10 years. But we do have data to say that it's safe and that it's trending towards something. So that's just kind of a discussion that you have with the patient. The Menopause Society's meeting in October is supposed to have data out regarding treatment in perimenopause using estrogen and progesterone in the perimenopausal period, and what the benefits are of starting hormone replacement early as opposed to waiting till women are suffering for a year and a half and they've not had bleeding and then say we can start their treatment. Treatment in the perimenopausal period is a little bit more challenging because your ovaries are still producing some estrogen and progesterone, right? And so trying to get a good treatment protocol where you're not having breakthrough bleeding or irregular bleeding is something that's a little bit more challenging than treating women that are just in the menopausal period.
How long can you be on hormone replacement therapy?
Yeah. So that's a
great
question. Yeah. So that's a good question. So the recommendations now are like 10 years, and discussion between age 60 and 65 are coming off. And we're kind of evaluating that with each patient when we get to that point. And looking at what their current health risks are and what new data we have out about the benefits of keeping it versus taking it off. Estrogen is one of the only things that's going to help with build bone. It acts on the, when your bones start to break down, you have osteoclasts and osteoblasts are the ones that build, and estrogen is the only real one that helps build bone back, not just stop the reabsorption. And so when you're looking at somebody who has a really strong history of osteoporosis, and you have a DEXA scan where they're borderline and they're 60 and they're talking about, can I use this safely for a few more years? Well, in an otherwise healthy person, there's probably good reason to continue that. The other thing, just of note, like in the perimenopausal period, that is hard to kind of negotiate is if we are using hormone replacement, estrogen and progesterone, it is not contraceptive. And so women do get pregnant sometimes in this period of time. So we need to make sure there's an unintended pregnancy in this period of time, because like I was talking about before, the FSH is yelling like, make more estrogen, make more estrogen. Sometimes it does work and you do ovulate. And so then, definitely had a grandmother in the 50s who got spontaneously pregnant at 47. So, it can happen. And so you want to just make sure in that patient population that you are counseling them, like, if they've had a tubal or their husband's had a vasectomy or they're just using condom or whatever. The hormone replacement therapy that is used is not contraceptive level. Does that make sense?
It does. And you just got a
Yeah.
question in the chat kind of along the same lines.
Okay.
This woman said, if you are on a low dose birth control pill because you don't want to get pregnant, will you stop having periods as you progress through perimenopause?
Yeah, that's a hard question. So no, you're going to continue to have like a withdrawal bleed. When if you're using the pill and then you stop it, whenever you stop it, you're going to have that withdrawal bleed. So it is kind of challenging to figure out where you are in that pathway when you're on oral contraceptive pill. The risk, like I mentioned, of blood clot is there with the oral contraceptive pill. And so it is just something to be aware of in terms of there are risks of thromboembolism with the oral contraceptive pill.
Another question I feel like a lot of women have that are in this stage of life, in perimenopause or menopause, weight gain is a significant concern. Does hormone replacement therapy help with weight gain? Could it cause weight gain?
Yeah, great question. So sometimes oral contraceptive pills, people feel like it does have a slight increased weight with that. But hormone replacement therapy, the way I'm talking about it with a patch and oral progesterone, does have weight. Most people have a weight loss with it, a little bit of a weight loss or a stabilization of their weight. The estrogen affects liver, and so that's as your estrogen falls, that's when you become more insulin resistant, and so you are going to have that weight gain. The best data for weight loss for menopausal women is not a GLP-1 or estrogen, but it's hormone replacement therapy and GLP-1 together. That's what the data is that would be the most effective for weight loss. And the weight gain is, it is a problem, and it's hard to figure out what's actually causing it, right? So if 40 to 60% of these women are having sleep disturbances and you're not sleeping, well, then your cortisol's going to be high, you're going to be snacking more, you're going to be, so it's really hard to kind of tease out what's causing the weight gain, but it definitely is something that I have women describe.
Yeah. I do want to cover some of these questions in the chat because we've got a lot and I want to make sure that we get to them.
Yeah.
I love that some people commented when we were talking earlier about social media, and some people commented and said that social media actually helped to make them more aware of their perimenopause symptoms and kind of brought everything to light for them. So I think that's great.
Yeah, I think especially with the brain fog, because women come in, they're like, I really was like worried if I was going through early Alzheimer's, and I just feel like I can't function. I can't do my job. I get angry at my kids. And so, the 40 to 60% of women are going to have some of this brain fog, and it's because of, the progesterone and the GABA receptors in your brain. Like, there are physiologic reasons why you're experiencing this. And so having women have a forum to understand that better, I think is really good. Lisa Mosconi is kind of one of the leading neurologists who's an expert in menopausal medicine. And I heard her talking with Mary Claire Haber, who's one of the, she has like the Pause Life. She's a prominent voice in this community. She said, if this is what Lisa Mosconi said, she said, if a patient comes in and says, I can't remember where my keys are, it takes me forever, I'm always losing my keys. She's like, that's okay. That's probably the brain fog with perimenopause. If someone's like, I can't remember what my keys do, that's probably something that I need to be evaluated for like early Alzheimer's. So, you're not going crazy if you just can't find your keys.
Yeah. I love that. I feel like this whole conversation has been very validating for women, that are listening, I hope they recognize that they're not alone and that we as women will all experience this at some point. So
Yeah.
we're
And
all in
I feel
this
like,
together.
yeah, I feel like that's one of the important things. Like, I want to go talk to church circles, and I want to like yell it from the rooftops and make a billboard and say, like, look, this is not like pathology. This is a norm. Like 100% of women are going to go through menopause. We should not be tolerating it as a disease state, but something that we can talk about and that we can give treatment options for. And hormone replacement therapy is not for everyone.
Mhm.
You know, there but we do have other options, to help
Let's
treat
talk about some of
this.
those.
Yeah.
But that was some of the
So
questions people have asked.
yeah. So
What are other things?
um, I want to say first and foremost that hormone replacement therapy is the gold standard, and it's the only thing that's going to give you some of the health benefits for your bone health, your cardiovascular health, everything else. But if those are not things that are effective, SSRIs, those are really effective with helping with the hot flashes and also sometimes with some of the mood symptoms. There's new medication called Veoza, and there's another. I'm sorry, I'm forgetting the brand name of the second one, but they work on the neurokinin receptors in the brain, affect the thermoregulatory sensations that are happening with menopause. And there's something that are safe to use indefinitely. And that was the one that had like a Super Bowl commercial a few years ago
Yeah.
about
I
treating
think
hot flashes.
I think they have
Um,
a commercial right now on
okay,
streaming
yeah. So
There's one I
you
can
know,
envision.
yeah. There are also, sometimes using a medication like Neurontin or like gabapentin can help with some of the hot flashes, and just using those at night. Sometimes those are helpful, but they are going to help with some of the symptoms. Definitely, they're not going to be as physiologic as some of the hormone replacement therapy is. It's interesting the new diagnosis women have in the 40s and their 50s of ADHD and anxiety and depression. And oftentimes when we give back these hormones and hormone replacement therapy, they're able to come off some of these other meds that they've been using to try to cope with the symptoms.
Wow. Someone said here, which I kind of feel like this kind of goes into conversation. This individual said, when is it time to demand HRT instead of just dealing with the symptoms? What would you have to say to that individual? Because it almost sounds like they're not feeling heard by their healthcare
Yeah.
provider.
Yeah, it is a really frustrating situation to have patients come to me and say, like, you're the fourth doctor I've been to, and nobody's listening to me, and I don't have a great answer for why there's not better education around this. Like, we're trying. There are women that are advocating. There's a bill that's just introduced in the Senate about menopausal medicine and trying to mandate a certain number of hours that are given to family practice, training around this. I, I don't feel like if you're not getting the response you need from your provider, get a different provider. You should
Mhm.
not feel like they're saying you need to suffer more before I'll give you treatment options. If you feel like your symptoms are bothering you, whether that's the libido, vaginal dryness, increased anxiety, like, you need to be offered treatment options, a full spectrum of treatment options.
Yeah,
Does that
I
answer
love
the
that.
question? I don't
It
know.
does. The
Yeah.
other day, it just made me think about the other day in our office. We were talking about having a gynecologist and having it be someone that you can trust. And I made a comment and I said, life is too short to not love your gynecologist. And we all giggled and we laughed, but it's true. Life is simply too short to not feel heard, to not feel seen, to not trust your provider. Um, yeah, so I know we all giggled, but it's true. So for that individual, I hope that you find that person. I hope you find that provider that's able to support you through every stage. Um, okay, Dr. Stille, this is something I've been wondering too, but
Okay.
someone put it in the chat. We want to know what the books are beside
Oh,
you.
sure. Yeah, yeah, yeah. Okay, so Mary Claire Haver has a new perimenopause book, and it's pretty good. I like it.
Okay.
Um, she has the pause life. That's her thing. And this book just came out in October. It's on Audible. So when you're folding laundry or washing dishes or whatever, you can do that. This one is this one. You want to see this one? This one is my daughter at the Women's March
Oh,
when she was a little baby in Alaska.
oh,
And
wow.
then the Menopause Manifesto is Jen Gunter, and she's a wonderful OBGYN who she wrote the Vagina Bible. She, discusses the origin of, this book is more like from historically how we thought about menopause and how that has transitioned into the care we're giving now.
Okay.
Let's see. This one is called Unbreakable, Vonda Wright, and it's one of those things that I am not an integrative medicine doctor. I will just say that up front, but I do feel like lifestyle is really important as you're transitioning into this perimenopausal period. And so there's got to be an emphasis on your diet and your exercise. And there's really great new research that's female specific on diet and exercise and what you should be doing in terms of trying to really, we talk about osteoporosis a lot for older women, but it's also sarcopenia or loss of muscle mass. And so you have to be really deliberate and like lifting much heavier weights than what traditionally I was thought to lift as an athlete. So anyway, Vonda Wright, she's wonderful. And then this other one, Mindy Pels she wrote Fast Like a Girl, she wrote Eat Like a Girl. And some of her stuff I don't completely agree with, but a lot of the stuff that is talking about eating like whole food, plant-based diets and talking about ketosis or like having a period of fasting for women in menopause, I think is really interesting, especially as you're struggling with the weight gain that happens.
Yeah. For all the girlies listening, I jotted down those books. I can send out a follow-up email to everyone and include those books in case you're
Yeah.
curious.
Yeah. And I think another book that I feel like there's a book called How to Menopause that I've had a couple of patients really feel like helped them. And that one is Tamal Asa. I can send you the name of it. Anyway, her book about menopause is more centered around her experience and how she had the symptoms of perimenopause and menopause and how that affected her work life, personal balance, and how she has then transitioned that into advocacy. And she's gone to Congress and tried to advocate for like menopausal leave and menopausal breaks for women. Because when we look at women in their 40s, late 40s and 50s, when they should be really leaders in their corporate field, they're leaving the workforce. And so part of that is trying to understand and support them through that. And so she's gotten through to speak at some big company events to kind of bring awareness around this for older professionals. But anyway, her book is really interesting.
I love that. And that one was How to Menopause.
Mm-hmm.
Okay. Okay, and then I have one more very serious question for
Uh-oh.
you that multiple people just put in the chat. Are you
Okay.
accepting patients?
Oh, yes. Sorry. Yes, I am. I'm kind of the outlier in this office right now in that I'm seeing some OB still and some GYN, but I'm mostly doing GYN. So yes, I'd love to see anybody that needs help with this.
I love that.
And shout from the rooftops, tell women that they don't need to be suffering, that they need to speak to a provider, that they feel heard, and that they get some of the care that they need.
I love that. People are chiming in after just talking about what you're talking about from the How to Menopause book. This woman said this definitely can change work productivity and toleration of sorts and should be brought to more light in workplaces as a medical issue.
Totally.
Yeah.
Totally.
Okay, Dr. Stille, we have 2 minutes left, and I've got one
Okay.
final question for you, which I feel like you kind of just answered it, but I'm going to give you another opportunity to kind of plug yourself. But if someone listening today, they feel seen by this conversation, and perhaps they've been suffering in silence, what do you encourage them to do next?
Yeah, I think that there are a lot of wonderful physicians who are doing outreach around this. I mentioned a couple of the names, and they have great podcasts, they have great audiobooks. Kelly Casperson's book is called The Menopause Moment, and it's really good. And, I think that there are a lot of caring women in this community that are trying to do the right thing in terms of offering women care around this. And I think that this is a really, women's health is a hard field to work in, but it is what brings me so much joy is when I see patients and, I see them come back for follow-up and they say, this has really, helped my life. It's helped my marriage. I feel like I'm back to myself again. Like,
Mhm.
what else could you want as a doctor to hear
Yeah.
that? So,
Yeah. Well, thank you so much, Dr. Stille. I think a lot of people really loved this conversation. I very much enjoyed it. I'm so appreciative that we have providers like you here in our healthcare system or here in our area, in our rural town. So I really appreciate you taking the time. I appreciate you
yeah.
being on the podcast. So for everyone listening, if you enjoyed this conversation, you will absolutely enjoy our conversation. Again, our podcast is in collaboration with High Country Radio, and it will air the first week of June, the episode with Dr. Stille and Dr. Coiner. But thank you all for being here. As always, what a lovely health talk. And Dr. Stille, thank you so, so much.
Yeah. Thanks a lot, Maddie. Bye.
Thank you. And then as everyone is logging off, your screen will change and you should have a survey. So please give Dr. Stille and I your feedback. Tell us what you learned. If you
Yeah,
didn't learn
please.
anything, let us know because we will change it next time.
And I apologize if
Um,
I said anything that was offensive or off the cuff. I don't know. Maybe I.
okay, you did not say anything offensive or off the
Okay.
cuff, so you are good. But thank you again, everyone. And we will see you for our next health talk in June, and it will be on wilderness medicine. So tune in next month. Bye, guys. Thank you,
Bye.
Dr. Stille.
Mhm.